Good morning,
Hello,
everyone.
am I audible?
Yes, sir.
Hello.
Yes, sir, you're audible.
Okay.
So, shall we begin the session with the permission of
Please,
judges?
please. Yeah, start.
Okay.
Good morning,
Good morning, sir.
Morning, sir.
Dr. Prasanna here.
Yes, Dr. Arvind, sir.
Yeah.
So, good morning, everyone. We welcome you to the 32nd. This
ಬೇಕಾ
we ask everybody to temporarily mute themselves because it is echoing. So, good morning, everyone. We welcome you to the 32nd State Level Annual Conference of Karnataka Association of Community Health by RMC, Ramaya Medical College, Bangalore. The theme for this year is redefining public health and beyond. With this, we shall begin our session on posture presentation. We feel very privileged to introduce our esteemed judges for the today's session, Dr. Arvind from GIMS and Dr. Prasanna Kamat, Professor and Head at STUM Kolar. We are thankful to you for dedicating your precious time to judge this event. Thank you, sir. Today's session will be moderated by Sejal and Divyanshi. And moving on to the instructions for today. Participants shall be given 5 minutes for presentation, following which 2 minutes shall be given for the questionnaire. We will be giving a reminder when the 1 minute is left, and at the end of 5 minutes, the screen sharing will be stopped. We request all the presenters and judges to go through the instructions once, and then we shall begin. Yeah. Judges, shall we start with our first participant?
Yes, you can start.
Okay, thank you, sir. So, our first participant is Dr. Philomena Zacharias. Do we have you with us? Hello, ma'am. We request Dr. Philomena to switch on their video and unmute yourself, please. We can't hear you, ma'am. I guess you have to speak without your microphone. Can't hear you. I still can't hear you, ma'am. No.
Can you hear me now?
Yeah.
Can you hear me
Ma'am,
now?
yeah. Should we share your presentation or do you
I
want to
can
present yourself?
I can share my presentation if you've given me the. Can I share from my? Is that okay?
Yeah. You can share your.
ಬಟ್ ಯಾರು ಸ್ಪೀಕರ್ಗೆ ಸ್ಪೀಕಿಂಗ್ ಮೈಕ್ ಬೆಟರ್ ಅಂತಂದ್ರು.
Can you see my presentation?
Yeah. Yes, ma'am.
Can you see it better now?
Yes, ma'am.
May I
Yeah.
begin?
Yeah.
May I begin?
Yeah.
Good morning, everybody. My name is Philomena Zacharias, and I would like to present today my study, Barriers to Antenatal Care During COVID-19 Among Antenatal Women Availing Routine Services in a cross-section study in a rural maternity hospital in Karnataka. COVID-19 is an ongoing pandemic for which a large number of asymptomatic individuals have been put at risk, especially those that would need to avail routine care services such as antenatal women. The guidelines from the Ministry of Health and Family Welfare state that all routine antenatal clinics and immunizations must continue even during government mandated lockdowns. The objectives of our study were to assess barriers to essential antenatal care during the COVID-19 pandemic lockdown. And they were also to describe the essential antenatal care service availed during the pandemic lockdown. Coming to our materials and methods, our study design was a cross-sectional study for which we estimated a sample size of 100, taking an assumed prevalence of 50% and an allowable error of 10%. We conducted our sampling through consecutive sampling. All women who were attended the OPD at our hospital were taken into our study, especially if they if only if they were pregnant during the pandemic lockdown, which we estimated to be 21st of March to 19th of May. The women who were admitted with labor pains, had critical complaints, or who were seriously ill were excluded from our study. A pilot tested face validated interview schedule assessing all socio-demographic variables along with essential antenatal care services availed and any barriers, both barriers of access and barriers of or psychological barriers, which are fears that they verbalize.
Connect ಆಗಿದೆ ಮೇಡಮ್, ಸ್ಟಾರ್ಟ್ ಆಗಿದೆ.
Hello.
ಶುರುವಾಗಿದೆ.
Were also taken into our were also asked of our participants.
ಸರಿ ಮೇಡಮ್, ಇಲ್ಲಿ ರೆಡಿ.
Ethical clearance for the same was obtained from the institution ethics committee of our institution.
ಮೇಡಮ್, ಅದು ಡೈರೆಕ್ಟ್ ಆಗಿ ಕ್ಲಿಕ್ ಮಾಡಿದೀನಿ, ನಿಮ್ಮ ಹೆಸರು
Coming
ಇದೆ.
to our results, coming to our results, a total of 144 subjects were participated in our study. The median age of our study participants was 24 with an interquartile range of 22 to 26. Our participants were also fairly well educated with the median years of formal education being 12. 56.9% of our participants resided in villages and 80.6% were from a joint extended or 3-generation family. Most of our participants were also in a good socio-economic status. As per BG Prasad scale, 31.3% were class 2 and 39.6% were class 3. As coming to the obstetric details, 62% of them were primary gravidae, with 75% of them in the 3rd trimester. When we asked them of the essential antenatal services availed during the pandemic lockdown, which I described before as the 21st of March to the 19th of May, we noticed that the more the interventions that were applied, for example, the more interventional the service was, for example, a blood test or abdominal examination or blood pressure measurement, the less likelihood of the antenatal woman having availed that antenatal care service. We noticed that 23% had not had their abdomen examined even once during the lockdown. 16% they had not had blood tests done, and equally for those who had to undergo ultrasound scans.
1 minute is left.
In addition to this, we also noticed that that women had both women had barriers to antenatal care services of 2 types. One was barriers to access, and the other was verbalizing fears. Of which barriers to access, lack of cash or ATMs, or lack of income was the largest barrier. Whereas the fear of getting infected with COVID or fear of not being treated properly if they went to the hospital were a large verbalized fear. Even though our barriers of access were mostly financial and our major fears included getting COVID-19, we found that the significant increase in both these barriers occurred in those with a lower socioeconomic status and those who lived in towns and cities. We would like to recommend, therefore, that local healthcare providers need to keep in mind these barriers while developing systems to ensure smooth delivery of routine antenatal care services during any further pandemic lockdowns. Thank you.
Judges, start questionnaire round now. Dr. Prasanna, can we start with the question?
Good morning, sir.
Hello.
Yes, sir. Good morning.
Very good morning. It was a neat presentation at the stipulated time. And my point is with respect to one of the result states that the lower socioeconomic status people, women
Yes, sir.
belonging to the lower socioeconomic class, were
Yes,
significantly more likely to experience the barriers.
yes, sir.
So, based upon what findings in your study did you conclude that it is
So
the lower socioeconomic status who are facing this as compared to the belonging to the class one?
yes, sir. I have displayed in my results tables that only the exact fears and the percentage of the people are done, but we actually also scored them based on these fears attained. If you notice, there are 16 psychological fear. That means, sorry, there are 16 barriers in total, 8 psychological fears and 8 barriers of access, for which each one was given 1 point.
No, no, no. My question was,
Yes,
you
sir.
have stated that the barrier are more among the lower socioeconomic status.
Yes, sir.
That means it is in comparison with the other classes.
Yes, sir.
So, what was the findings difference between these two groups which made you to conclude that? Because that's one of the
So,
important findings what you have projected.
yes, sir. So when we scored them, we found that the those of the lower socioeconomic status had a higher score for barriers than those of the higher socioeconomic status.
How
When
many
we
of
scored
the
them,
study sample belong to the higher class and the lower class?
so 31.3%, about 60% in were actually totally of class 2 and class 3.
Hmm.
And the rest were, which is about 40%, would be of the lower socioeconomic status. So we had done a Kruskal-Wallis test also to measure the difference between their barrier scores. But we have taken our outcome variable, which is our barrier scores, to be that a score and not in as a percentage as we have shown it here. So which is why that sentence that I have put up in my conclusion.
Okay, thank you.
Thank you, sir.
Dr.
Sir?
Uh, Dr. Arvind, can you hear us? So we shall move to the next presenter. Sir, shall we move to the next presenter?
You can go ahead.
Thank you, sir.
Okay, sir. So moving on to Dr. Vishala.
Good morning.
Do you want us to present your screen?
Yes. Thank you.
Are you able to see the screen?
Yes, yes, I'm able to see the screen. So can you all hear me clearly?
Yeah.
Yeah. Can I start with the presentation, sir? Nothing I should do. So can I start the presentation?
Yes, please.
Yeah. Good morning, everyone. Good morning, sir. I'm Dr. Jobrit Venchula. So I would like to present my paper on influence of media, including internet and smartphone applications on infant and young child feeding practices among mothers of children under 5 availing healthcare services in a rural hospital in Ramnagar district, Karnataka. As we all know, maternal and child health component has been the key factor of focus for the government of India since independence, like from 1952 itself, the program starts. So appropriate infant and young child feeding practices are key strategies to reduce under 5 mortality. And being in the digital era, increasing mobile technology penetration in the rural areas can have an influence on these IYCF practices. Why we wanted to do this study? Information communication and technology tools such as mobile phones and computers have been increasingly penetrated and have been used as a positive way to influence or bring about behavior change communication under various national programs, including our ML strategy. And which is previous years it has been used in HIV, family planning, and National Tuberculosis Elimination Program. So we wanted to explore the potential for using media to improve quality of IVCF practices in the rural communities. The objectives of a study were to assess the IVCF practices among the mothers of the children under 5 and its associated factors in a rural maternity hospital, Ramnagar district, and to study the association between media usage, including internet and smartphone, with the IVCF practices. It was a cross-sectional study we conducted among 89 mothers of children under 5, and we used a face-validated semi-structured interview schedule, which had information on socio-demographic and obstetric details, and we detailedly collected about the IVCF practices followed by the mothers, which includes initiation of breastfeeding, exclusive breastfeeding, and time and introduction of complementary feedings. And what was the mobile media usage among that particular population? We used a consecutive sampling to reach our calculated sample size. So the results of a study were the mean age of the study population was between 23 years with the standard deviation of 3.5 years. The mean years of formal education was 14 years with the standard deviation of 2.1 years. Majority of them were unemployed, and mean age at marriage was about 20 years. So we have given the breakdown of the age group of the children of the mothers. So we had about 39.3% of the children between the age of less than 6 months, and 49.4% between 6 months to 24 months, and 15.7% between the age group of 2 to 5 years. So as we can see, the IVCF practices of this particular community or the study population, almost every one of the study have breastfed the children, and 78 of them have initiated breastfeeding within 1 hour. And the mean duration of exclusive breastfeeding among the children between age of 6 months to 24 months was about 6 months with a standard deviation of 3 months. And none of them have given any form of prelactal foods. So moving on to the media usage of the community, almost everyone had the access to the smartphone, which could be either their own or it can be owned by any one of the family member. And one who's owned their own cell phone was about 51%, and about 57.3% had access to internet. And they've almost used WhatsApp, Google search, and YouTube videos for using the internet, from the internet. So when we questioned about what was the source of health information for them regarding IVCF practices, majority of them reported primary healthcare providers such as doctors, nurse, ASHAs, and ANMs to be their primary source of information. Where moving on to social media, only about 15 of the individuals have used, out of the 18, and only 15 of the individuals have used access to media to search for information with regarding to infant and child feeding practices. But none of them felt the information provided from the internet was reliable or credible. And we were not able to find any significant association between the media usage and the IVCF practices in our study population. So the findings from my study, I would like to conclude that the IVCF practices of that particular study population was much better than the national average, and majority of them had access to smartphones, but only half of them had access to internet, and none of them reported media to be a primary source of information with regards to infant and young child feeding practices, and significant proportion consider healthcare providers as their primary source of information. So this emphasizes the work of provided by primary care physician and grassroots level workers in imparting knowledge to the mothers, especially mothers of under 5 children, about IVCF practices. And the scope of using media to bring about behavior change communication in this context can be explored.
Ma'am, time.
Thank you.
Good morning,
Good
Dr.
morning, sir.
Vinsula. It was a nice presentation.
Yes, sir.
My first question would be,
Yes, sir.
what made you to, I mean, the rationale, I mean, in the introduction you have told, you wanted to explore the usage. Could you please more upon that?
So, yes, sir. Yes, sir.
Intention for the study.
Yes, sir. Actually, sir, when we started the study, the concept behind was majority of the developed countries have formed groups in media to bring about information regarding breastfeeding and breastfeeding support groups in developed countries. But this practice has been tried to adopt in developing countries because most of the developing countries are facing undernutrition or malnutrition problem, especially poor breastfeeding practices. So, and a nearby country, that's Bangladesh, has recently tried doing an interventional study using mass media, providing information to the mothers and combination with other routine standard care to bring about behavior change communication. So, if our country wants to adopt such kind of practices, since we have already used media in various programs, we wanted to see whether the community itself has media usage, or how well they are accessing the media without knowing the. Sorry, sir.
Okay, I have understood. Got the point. Now, would you like to mention any limitation of your study? Any limitation of this particular study to attain your objective and ultimate goal of utilizing the services?
Yeah, so the limitation of the study, one thing could be, first of all, those who all have a phone or the media might not actually use it, or those it can be in a home used phone, meaning the family member might have the phone, but the women in the particular household may not be having access to it. So what we, one is that, sir. The second thing could be when we asked about the practices with respect to IVCF, that could have been a social desirability bias, that they will try to say everything because it's a doctor who is asking them questions. They might try to tell whatever they are doing is correct, or they may not tell us the real truth what they are practicing. Yes, sometimes.
One more opportunity. Any other limitation which you have mentioned? One is phone or somebody else is being used. The second one is IVCS, whatever it is. Any other limitation which you could have approached by asking one simple question or two questions? Can you think of any such limitation which you could have addressed one or two questions in the questionnaire?
With respect to
whatever
media,
you told is absolutely right.
Yes, sir. Yeah, the limitation is with respect to media usage or about IVCF practices, sir? Which you want?
Usage.
Usage.
Any limitation you can think which you could have overcome?
Network or package, something with related to the network, sir? Sorry.
I think
Yes, sir.
one question could have been the content they browse for using the social media. Because if their intention is only for that entertainment purpose, how many of them you think would be interested in using this? So at least that one more question regarding the purpose of usage could have been included was my thinking.
Sorry, sir. Actually, we have got that information, but I couldn't put it in this. We've asked the mothers who have the question was, when media usage, the question was, if you use, do you use media with respect to any of this WhatsApp, Google, to search information with respect to infant and young child feeding practices? If they say yes, the next question was, what was the information you looked upon? Was it regarding breastfeeding? Was it regarding any health related queries? Like that, we had a division, sir. We had
Yes, absolutely
sports.
right. If you had done that, then
Yes, sir.
isn't it the important
Yeah,
for
yeah.
exploring that as
Presentation,
the
yes, sir.
source of, because ultimate aim or goal was
Yeah.
how it can be explored.
Yeah. Yes, sir. Yes, sir. Correct, sir. Sorry. I should have put it in my results. Because the thing is, only very few people have used. I mean, 15% of them, 15 members out of 89 have used. So that's why I couldn't put that. But we have asked, sir. I agree with you. We should have put that in the results.
Thank you, Dr. Jobre.
Thank you.
Arvind, do you have any questions?
Now we'll move on to our next presenter.
Thank you.
Do you want us to share your presentation?
May I share my own?
All right.
Can you hear me?
Yes, you're audible. Yeah.
Good morning, everyone. Esteemed judges. The title of my poster is A Cross-Sectional Study to Assess the Quality of Health Information on COVID-19 Treatment on the Internet using the Discern Checklist and the HON code or Health on the Net Foundation code. Introduction. The COVID-19 pandemic has led to a pandemic of myths and misconceptions about the disease. This is particularly true in the internet medium because most of the people are now confined in the homes as a result of the lockdown and because of quarantine, and they often use the internet as a source of health information. These myths and misconceptions are as a result of fear mongering and for financial gains, and this seriously undermines the efforts of the governments and other health service providers in conveying the accurate information. So, the objective of this study is to assess the quality of health information on COVID-19 treatment available on the internet using tools and this cross-sectional study has a to do the was conducted on a power.
Ma'am, can you please pause for a minute? These judges are not there.
It was searched on 5th December.
Excuse me, ma'am. Dr. Nasreen. Dr. Nasreen.
Dr. Prasanna, are you there with us?
Yeah. Just now, there was a problem technically. I am hearing.
So,
Go ahead. I'm not seeing the screen. I mean, it is not visible.
yeah,
The
she's there.
screen,
So there's some
the screen is
connection at your side, I think.
at my side. No, I am seeing Nazreen PM is starting to share content that is displayed.
Yeah.
After that,
Her presentation is visible.
my screen shows Nazreen PM He is starting to share the content. I am able to hear the background voices, but the screen is not.
Hello. Hello.
So can you hear us?
I am
I'm
hearing,
trying to
but I am
share
not
some
seeing the
network
screen.
issue.
I am
So
seeing
there's
Dr.
some
Nasreen
problem.
also.
Dr. Nasreen,
Uh,
can we share your presentation?
Uh, Ma'am, you can turn off your video so that the connection is proper.
Yeah,
Yeah,
we
yeah,
can.
yeah.
But you can turn off the video so that the connection.
no, this is fine. This is fine, please.
All right.
Go
So,
ahead.
sir,
Go ahead. Go ahead. Go
begin
ahead. Go ahead.
presentation again.
Continue. Continue.
Now it is visible. You can continue.
Okay. Thank you, sir. So, a web
Yeah,
search
please.
was conducted on public computer with McAfee antivirus software in Google Chrome with COVID-19 search term COVID-19 treatment on the 5th December 2020 at 11 a.m. with Bangalore given as location in incognito mode. Incognito mode was used in order to reduce the bias in the search results and to make sure that the Google search results as obtained in the study was the same as that of a lay person who would be searching the exact same terms in Bangalore, Karnataka. The top 84 websites were and analyzed. The tools used for the analysis were the discern checklist, which is a short questionnaire containing 16 questions and a score ranging from 1 to 5, and the HON. The HO certificate is a WHO approved seal that is provided by a foundation called the Health on the Net Foundation. This foundation voluntarily audits the websites, and if the websites are complying with the 8 rules of conduct of the Health on the Net Foundation, the certificate is given to that particular website. For an online user to find out whether the given website in question has an HON code certificate or not, the Health on the Net Foundation has a downloadable app or an extension which can be used to find out whether this website has a certificate or not. Once a consumer enters the website in question, if it has the HON code certificate, the extension on top of the web browser will change color. If it doesn't have the certificate, the extension remains colorless. The inclusion criteria were all the websites from the Google search and all websites were irrelevant to COVID-19. Country websites and medical literature sites were excluded. The results of the study, 83.4% of the websites analyzed were commercial educational websites, 7.1% were governmental websites, both Indian as well as non. 6% were websites of non-profit organizations, 3.5% were other websites like blogs and other miscellaneous sites, and with regard to code certification, only 14% of websites had the HON code certificate, the rest 86% did not have it. And with regards to the discern score, only 16.6% had of the websites, analyzed websites, had high discern scores of more than 65. 9.52% had moderate discern scores of 33 to 64, and 73.8% had websites with low discern scores. So, the conclusions I would like that most of the websites analyzed were commercial educational websites which had low discern scores. Websites in the first page of the search, which is where usually the users browse, had high discern scores but did not have the HON code certificate. Government websites had moderate to high discern scores, meaning they had high quality information, but they had outdated HON code certificates. The HON code certificate has to be updated or recertified annually. The recommendations which can be drawn from this study are that strict government regulations and guidelines in the internet medium must be there in order to ensure the quality of online health information. Health education and awareness must be given to online consumers, and it must be stressed that not all the information in the internet is true. The limitations of my study are that the extensions used to find out whether the code certificate is there or not, it may bias the search results. And some websites, despite having high discern scores or high quality information, may not have the HON code certificate because they were not aware of the HON code certificate. And COVID-19 being a rapidly evolving new disease with multiple updates, it is not practical to anticipate all the websites to have all the information regarding all of the treatment options. These are my references. Thank you.
Hello.
Thank you, Dr. Nasreen. Can we start with the questionnaire round?
Yeah. How did you calculate the sample size? Hello. Am I audible?
Yes, sir, you're audible. Yes, sir.
Yeah. This is a question to Nasreen. How did you calculate the sample size?
So the sample size was based on a previous study conducted by Juan Baltazar, which showed that 70% of the websites that they analyzed had low discern scores. Based on that, I calculated the sample size to be 84.
You give a recommendation that the strict government guidelines regulation should be there.
Yes, sir.
Have you conducted any study on that? Like by implementing the strict government regulations, we can decrease this, or you can have better design score, high design score, and the certificate should be present.
Sir, you're not audible, sir.
No. Have you conducted any research on including
Yes,
or
sir.
like implementation of strict government guidelines or regulations? Can have a quality information on the online websites.
No, sir, I have not done a research on that topic.
Then
I
you
feel
cannot give any
like some.
Then you can no. Then you cannot give recommendations. Okay. So the whatever the
Okay, sir.
recommendations you give, it should be depends on your study results.
Okay, sir. Okay.
I hope you got my point.
Yes, sir.
Yeah. Okay.
Good afternoon, Dr. Nasreen. It was a timely study done for this pandemic and the utilization of the web-based sources for the information.
Yes, sir.
Just like the other gentleman who told that government regulations.
Yes,
So
sir.
in your study, only 7% or 7.1% of your website are the government website, right?
Yes, sir. Yes, sir.
Okay. So just based upon that 7% of your sample size, your conclusion that government regulations strictly has to be implemented to take note of the content is not justified. So if at all you want to persist with that, what else could have been done to strengthen your conclusion? What could have been done to strengthen this conclusion that strict government guidelines? What is that element which
Because
you could have included in your essay or survey?
which are the sites which have more traffic based on that?
Come again?
Sir, I don't know, sir.
Okay. Thank you.
Thank you, sir.
Thank you, Dr. Nasreen. So moving on to the next presenter, Dr. Divya Bharati. Do we? Dr. Nasreen, can you stop sharing your screen? Dr. Divya, should we share your presentation?
I am not able to share my content.
Content is shared.
Yes.
Dr. Divya, your time starts now.
1 minute. Shit.
Can you make it a slideshow mode?
Fine now? Am I
Yeah, it's
audible?
fine now. You can start now.
Okay. Good morning, everyone. I am Dr. Divya. I'll be presenting my poster today. The topic is Trend Analysis of Retroviral Positive Subjects Attending an Antiretroviral Therapy Center in Urban Bangalore. Coming to the introduction, HIV infection in India is a public health problem. The incidence of HIV has been declining over the years. Poor compliance of antiretroviral therapy affects the progress towards NACO strategic plan by 2020. Coming to the objectives, my first objective is to describe the trend of retroviral cases at an ART center in the last decade. Second objective is to assess the adherence to treatment among the new cases in 2019. Materials and methods. My study design is a case record analysis. The samples settings data of treatment cases on adherence.
Ma'am, you can switch off your video if there is some problem.
And transfer in 2019 were excluded from
Ma'am, you can switch off your video if
Hello, is there a technical problem?
yeah, Dr. Divya, you can switch off your
fine.
video if there.
I switched off. Am I audible, ma'am?
Yeah, yeah, you're audible now.
Okay. Coming to the results, this is graph 1. It shows the yearly trend of cases from 2009 to 2019. The green line represents the registered new cases every year. We can see that in 2009, it is 827, which declines over the year. And in 2019, only 116 cases were registered. The blue line shows the death related to HIV. In year 2009, we can see it is 135, and over the year it declines and it is coming to almost 9. The yellow line represents a combination of loss to follow-up, missed and stopped cases. We can see that that is also declining over the years, and in 2019 there were 0 loss to follow-up, missed and stopped cases recorded in that ART center. Coming to the second graph, it shows trend on typology of HIV infection in the last decade. In this graph, we can see that HIV in India is driven by sexual transmission. The blue graph, the blue portion shows the heterosexual transmission. The purple is male sex with male. The blue is mother to child transmission. The yellow content shows the female sex worker. The green is intravenous drug users and red is unknown. Coming to the adherence of treatment, in 2019, 97 cases were registered and they were followed up for adherence. In that, 56 males showed adherence more than 95% and 31 females showed adherence more than 95%. Less than 95% was seen among 3 males and 7 females. On applying Z test for proportions, we find that the females are less adherent to compared to males. Coming to the strengths and limitation, a decadal data on trend of retroviral cases was available for comparison. Case records analysis did not have all the information. That is the limitation of my study. Coming to the conclusion, a declining trend of new retroviral cases, deaths, and loss to follow-up was observed. The adherence to treatment was 89% in my study. Recommendation, the counseling services to retroviral cases strengthened to increase compliance. These are my references. I acknowledge the staff and the cases attending the ART center. Thank you.
Thank you, Dr. Divya.
Good morning.
Good morning, sir.
Okay. My simple question is, in your study, there is a declining trend of new cases in the past decade, right?
Yes, sir.
So what is your opinion on this?
Sir?
And what is the observation is there is a declining trend of positive cases being registered. That is a
Yes, sir.
statement. So
Yes,
what
sir.
is your inference?
So my inference is that the National Organization of working very well, and they are implementing all the programs very well in all the ART centers. And I can also see that they are achieving their goals, the National Strategic Plan, which is to identify 90% of the people to be diagnosed, and among that 90% to be able to be on treatment, and 90% to have less the viral suppression.
No, 1990 तो अलग की बात है. So the statement in your conclusion is there is a declining trend of new cases registered in the past decade. My
Yes, sir.
question was simple. Do you look up to this statement in a positive attitude or negative attitude? Is it positivity or negativity?
Positivity, sir.
And you contribute all that to the work of the NACO and the various NGOs involved in that.
Yes, sir.
Thank you.
Thank you, sir.
Hello. Hello.
Yes, sir.
Yeah, in continuation with the Kamath sir's statement, the NACO may not be working properly, like because they're not reporting more cases. Other way, you told it is a positivity, it may be negativity also.
So I don't think I mean, it could be negativity, but then I feel they've worked hard, and there is a lot of awareness among the general population. They also want to get themselves tested, and ITCT centers are also working to increase awareness everywhere and identify the cases.
Or it may be due to some lockdown, people are not turning up to the hospitals for the treatment or some investigations.
Sir, but then it was not just, it has declined over the period, so I would like to think that it is because there is decrease in the infection, sir.
Okay.
Okay. Is there any, Dr. Divya?
Yes, sir.
One stakeholder I don't think you have been given credit to, which is that other important stakeholder for this declining trend, which you haven't credited. One of the major stakeholders of this particular, it may be an endemic or it may be whatever you want to call it as. It has become an epidemic proportion. Who is that major stakeholder whose contribution whom you have not appreciated here?
I don't know, sir. Sorry.
Awareness of the people so that they don't indulge in this
Yes, sir.
unprotected sex with the strangers. See, the NGOs, the government agencies, they are all doing. But
Yes.
without the people contributing by adhering to those health education materials, how could this have been possible?
Yes, sir.
If without the contribution of the people, if it was possible, then I would like to think on the negative aspect as Dr. Arvind told. The people are not reaching those who are in the most risk group to identify them and bring into the loop. So now, if given a last opportunity, whom would you like to compliment for this achievement?
General population, sir.
Thank you very much.
Thank you, sir.
Thank you, Dr. Divya. Next participant, Dimple and Diaz. Dr. Divya, can you stop presenting? Dr. Divya? Dr. Dimple, do you want us to share your presentation?
Yes, please do.
Can you see the screen?
Yes, yes.
All right. Your time starts now.
Good morning, judges and fellow postgraduates. So the poster that I'm going to present on is on acceptability of nutritional assessment methods, deciphering perceptions of women in coastal Karnataka. So coming to the introduction, anthropometric measurements supplemented by dietary assessment using dietary surveys help to assess nutritional problems in a community. They have been used in clinical practice and epidemiological studies, but their acceptance is being seldom studied. So there were two objectives to the study. One was to assess the perceptions towards acceptability of different anthropometric assessment methods, and the second to assess the perceptions towards acceptability of dietary intake assessment methods among women of reproductive age group. So the study was a cross-sectional study consisting of 288 women and of reproductive age group, that is 18 to 45 years of age. The study setting was from a selected village, Pavur, in the Rural Health Training Center, Harekala area of Dakshina Kannada district in Karnataka. We used a semi-structured questionnaire using EpiCollect 5, a mobile-based free application. The method of data collection, anthropometric measurements were taken, and dietary assessment methods were demonstrated or explained and asked for their acceptability. Coming to the results, table 1 shows the perceptions towards acceptability of different anthropometric methods. So 99% of the participants found that all the anthropometric measurements except neck circumference were acceptable. The highest acceptance rate was for weight, about 99.3%, and the lowest for neck circumference, 98.6%. The perceptions towards acceptability of methods assessing dietary intake showed that the maximum acceptance was for weighment of cooked food, followed by 24-hour recall method, and the lowest acceptance rate was for weighment of raw food. Coming to the strength and limitation of the study, the strength of the study was that the study is on perceptions of women about the acceptability of methods of nutritional assessment. Is in Indian context is rare, and random sampling was used for selection. That also formed the strength of the study. The data was the quality of the data was assured because it was real-time data capturing using EpiCollect 5. Coming to the limitation of the study, it was that the generalizability was limited because the study was conducted only in one village, so the findings cannot be generalized beyond this village. The study did not include a qualitative component which could have given us more insight into the problems. Coming to the conclusion, the anthropometric measurements and dietary assessment methods were perceived as acceptable by majority of the women. And the recommendations were for generalizability, similar studies can be done in larger population. The following were the references. T. Byers, M.A. Bowen, D.J., Quattromoni, P.A., and Quinn E. and Quintlani, L.M., who had studied feasibility and acceptability of dietary intake assessment via 24-hour recall method and food frequency questionnaire among women with low socioeconomic status, and concluded that both the 24-hour recall and food frequency questionnaire was equally accepted among the participants. Among Srivatsava SR, Srivatsava PS, Ramaswamy J were authors of a study known as the titled Assessment of Nutritional Status in the Community and Clinical Settings. They had concluded that the 24-hour recall method and food frequency method and weighment of raw and cooked food were acceptable methods and came to household dietary assessment methods. The acknowledgements for the study for Dr. Madhavi and Dr. Himan. Harshita from Center for Nutrition Studies, Yanapoya deemed to be University. Thank you.
Thank you, Dr. Dimple. Dr. Prasanna.
Okay. Good afternoon, Dr. Simple. Very nice
Good
effort
afternoon, sir.
in, performing a study upon this untouched area.
Thank you, sir.
So my question would be, since you have selected to tread the untrodden path, what was the main reason for you to think that this is the area which is least visited? Can you reason out?
Sir, during during our clinical postings, many of the patients were seemed very uncomfortable with certain anthropometric measurements and even with dietary assessment methods. So usually when a patient comes to even if it's in the household setup or in the clinical setup, when a patient comes, it is generally taken for granted that they are willing for certain anthropometric and dietary assessment, and we do it without keeping their interest in mind. So I felt that understanding their perceptions and taking the appropriate methods in accordance to their need is required.
Okay, so you tell that among those few families who you came across in the field study, you thought of doing this and identifying how much amount of is acceptable. Fair enough. But in the conclusion of this, you tell the limitation is it can't be generalized because of the sample size.
Yes, sir.
So
And
how
because
do
it
you
was done
think
on
these 2 points?
sir.
How do you think these two are at the extreme match each other?
Sorry, sir, I couldn't get the question.
Yeah, repeat. So the beginning of your study was you coming across few women or the mothers who were not comfortable with these measurements and weighment of the food and whatever dietary assessment. That was the triggering point for you to start a study, as
Yes,
expressed
sir.
by yourself.
Yes, sir.
Fine. So you ventured upon to identify, and the result clearly says that 99% of them didn't have any problem at all, and every one of them was acceptable.
Yes, sir.
So is this not a sufficient evidence? And
Sir,
to state that
yes.
few mothers whom you came across were only exceptions, which should not be a reason for changing the present existing practice.
Sir, in how the study was conducted was that we basically explain to the mothers and then we do the measurements. So upon explanation, it was found to be like the mothers had a higher. I mean, not the mothers. The women had a higher acceptance rate.
Okay, you mean to say the healthcare workers, the ANMs or the ASHA workers or whoever the grassroots health workers, you feel that they won't explain what they're going to perform and then they are going to get, so there is objection?
Sir, sometimes regarding certain, I
No,
mean,
no,
in
no. Why?
yes, sir.
Why? Because your second reasoning was why there is more acceptability in your study is because you explain to the mothers and then you perform those things.
Yes,
So,
sir.
by stating this and going by your first take, is that not we are without reasoning, we are judging that the grassroots level health work not explaining to the mothers properly what they are supposed to do and what they are doing and what is the purpose of their doing?
So, as such, we have not judged the grassroots workers as such
Fine,
by
thank
the
you.
study. Yes.
Sir, 2 minutes are up.
So shall we move on to our next presenter?
Please, go ahead.
Dr. Suman Saya.
Can
Do you
I
want
share
us
my
to
content?
All
Can I
right.
share my content?
ನೀವೇ ತೋರಿಸ್ಬೇಕಾ ನಿಮ್ ಕಣ್ಣ?
Is my slide visible?
Yeah, it's visible.
So, good morning, judges and my dear colleagues. I'll be presenting a study that is titled Awareness Regarding Early Childhood Development Among Young Mothers Availing Health Services at a Maternity Hospital in Rural South India. So, according to the census 2011, early childhood developmental delays affect about 10% of Indian children. And because of neuroplasticity, an early intervention of these developmental delays will enable better outcomes later in life. And mothers, especially in the Indian setting, as primary caregivers of children, play a pivotal role in early identification and timely seeking of care for early childhood developmental delays. The objective of the study was to assess awareness of early childhood developmental milestones and identify factors influencing awareness among mothers of young children availing healthcare at a maternity hospital in rural South India. The study design was cross-sectional. It was a hospital-based study, and mothers with a child less than 3 years of age availing health services at the hospital were included in the study. The sample size was calculated based on another study done by David et al. And it was the sample size that was arrived at was 156. A face-validated interview schedule was designed, and in addition to socio-demographic factors, 4 items captured the knowledge regarding risk factors associated with delayed milestones, and 32 items captured knowledge regarding early childhood developmental milestones across 4 domains, that is gross motor, fine motor, social, and language. And each of these awareness questions was, if answered correctly, was awarded 1 point. It was a consecutive sampling technique was adopted for the study, and mothers whose children were admitted in the ICU were excluded from the study. The average age of the participants in the study was 23.8 years, and most of them were educated up to the 12th standard. Only 7.7% of the participants received health education regarding ECDM by a community level health worker who could be an ASHA, an Anganwadi worker, or an ANM. The overall maximum possible score was 36, and the mean score that was obtained was 12.4. So this shows us that the overall knowledge regarding ECDM was altogether poor among all the participants. The following graphs show us the proportion of mothers who were able to correctly, accurately tell us by what age a child should be able to achieve the respective milestones. So among the gross motor milestones, the age at which a child was expected to roll over was the most popular. And among the fine motor milestones, the age at which a child was able to scribble, and among the knowledge regarding social milestones, the age at which a child would be able to recognize a mother, and the knowledge regarding language milestones, the age at which a child would be able to speak clearly, were the milestones that most of the mothers knew. When a bivariate analysis was done with regard to the socio-demographic factors and the knowledge source,
we found that the years of formal education and those who received education regarding early childhood developmental milestones by a health worker were significantly associated with higher awareness scores. When these factors were introduced into a multiple linear regression, the association remained significant. The strengths of the study is that the scientific articles on maternal awareness of ECDM, although pertinent, is scarce, and this study adds to the literature. And as this was a hospital-based study, this with consecutive sampling, the results cannot be generalized to all rural areas. The conclusion is that awareness among rural mothers regarding ECDM across all 4 developmental domains was found to be inadequate, and poor maternal awareness is likely to hinder early recognition and intervention for early childhood developmental delays. The recommendations that I would like to make are the community level workers must educate mothers with regard to ECDM at every opportunity that they come in contact with them, and they can also use the mother and child protection card as an educational tool. The following are my references, and I would like to thank the Snehalaya Hospital Administration staff for allowing us to conduct the study. Thank you.
Thank you, ma'am. Can you begin the questionnaire round? Prasanna, sir.
Good morning.
Good morning, sir.
Very nice effort from Dr. Suman. My question is pretty simple and straightforward. For your conclusions, were there any bias which you could have addressed, or which you would like to include in your future study if it were given an opportunity? Was there any bias noted after the study? If that could have been addressed, I could have done a better job like that.
Firstly, maybe it was a hospital-based study, so I not captured what is there in the community. So already, but I'm not sure if that's a bias.
That is not the bias. I am asking about what was the bias which you think could have been addressed after the study was completed.
I'm not sure.
Why? Because the inclusion criteria says that all the mothers with a child under 3 years, they're right.
Yes, sir.
So, among your study sample mothers, how many of them have children less than 1 year? An infant, how many of them are children less than 3 years and 2 years? Anything ringing
I
in
have
your
not.
mind?
Okay, with regard to maybe those mothers with younger children should be targeted.
So, what is the bias now?
A bias is a systematic error. Sorry, sir.
Then my question would be, what is the difference between a systematic error and a bias? Don't make me to ask Viva questions. No, I have given the clue also. I have given the clue also. How many of those mothers whom you included? Because it's a wide area. Any mother with children less than 3 years are included, right? So there may be mothers who are having an infant, who are having a second-year child, toddler, and so now. So what is the bias? What do you think I am asking? Because one of the important
maybe
conclusions
because
state
they
that
are.
one important research you identified is those who have received health education during pregnancy regarding the milestones.
Yes, sir.
So this component along with the earlier information.
So those mothers who recently delivered a child or who had a health education session during her pregnancy would probably remember
So the
better.
bias is? So what is the
That
bias?
I'm
It's
not
simple.
sure
What are you trying to recollect now? You're recalling, right?
memory. Yeah, recall bias. Yes. Sorry, sir.
Fine, thank you. So, if given an opportunity, how do you think this can be addressed? To strengthen the statement,
Maybe reducing the age of like a mother of an infant would probably have a smaller a recall period or an almost uniform recall
you're
period. That
not
is one.
audible.
The other thing is to have a education
Okay,
session and then maybe
okay,
after
fair
6
enough.
months.
Okay, fair enough. Now, how can you convert this into an interventional study to strengthen your? Hello,
Yes, sir.
uh, can you convert this into an interventional study to strengthen this statement?
So the intervention would be a health education session for all the mothers in the probably in the antenatal period, or maybe we could even stick to one trimester, the third trimester or the first trimester, and then follow all of those mothers up over a period of time and find out how their knowledge has improved. So we would have a baseline knowledge score and an endline knowledge score, and then we can find out whether there was any improvement because of the intervention.
Okay, ma. Very well stated. Good luck for your future interventional study then.
Thank you, sir.
So next up, we have our last presenter, Sangeeta.
ಇನ್ನೊಂದಿದ್ಯಾ? ಆಯ್ತಲ್ಲ.
Yes, ma'am. Good morning. Can you share my
Yeah, best.
poster, ma'am?
ಸರಿ ಇನ್ನು ಮುಂದೆ ಬರ್ರಿ ಯಾವುದೇ ರೀತಿ ಸ್ಥಳಗಳು ಇರುವುದಿಲ್ಲ ಇದನ್ನ ಎಲ್ಲ ವಿದ್ಯಾರ್ಥಿಗಳನ್ನು
Can the others mute themselves? Yes, sir. Can you see the screen?
Yes, ma'am. Am I audible, ma'am?
Yeah,
Yes,
you're
ma'am.
on.
You may start now.
Okay, ma'am. Good morning, judges, organizers, and my fellow postgraduates. I'm Dr. Sangeeta,
Ma'am,
junior resident.
there's a lot of background noise from your side.
Oh, ma'am.
Now it's fine, ma'am. You may start.
Okay, ma'am. I'm Dr. Sangeeta. I'm a junior resident from the Department of Psychiatry, Chengalpet Medical College, Tamil Nadu. My study is titled A Study on Self-Efficacy Among Alcohol-Dependent Patients During Forced Abstinence Due to COVID-19 Pandemic. So, introduction. Since the national lockdown since March 2020, the alcohol-dependent patients has facing the difficulty in the non-availability of substance, which has resulted in development of withdrawal symptoms and even suicides among the patients. So our study focused on the self-efficacy of abstinence among the dependent men due to forced abstinence. Coming to the objectives, we studied the socio-demographic, clinical characteristics, severity of alcohol dependence, and their influence on self-efficacy of abstinence among the alcohol-dependent patients. So our study is a facility-based cross-sectional study design with a sample size of 50. Our study population includes the alcohol-dependent patients who fulfill the dependent syndrome criteria of ICD-10 who are attending the de-addiction OPD. So we administered a semi-structured questionnaire, severity of alcohol dependence questionnaire, Institute of Withdrawal Assessment Scale to identify the withdrawal symptoms, and alcohol abstinence self-efficacy scale. We used simple random sampling and For the statistical test, we used chi-square and Fisher's exact. Coming to the results, of the 50 patients, 27 had a high self-efficacy and 23 had a low self-efficacy. And we studied the association between various variables and the self-efficacy. We found that those with more than 50% financial strain or reduced income had a low self-efficacy, which was statistically significant, and higher the level of the severity. That means the moderate to severe alcohol dependent patient had low self-efficacy, which was significant, and those with withdrawal symptoms had low self-efficacy, and this finding was also statistically significant. Whereas variables like age, occupation, income, quantity of drink were not statistically significant. Coming to the strength, we used an adequate sample size with the validated questionnaire, and the limitations would be this is a hospital-based study, though the results cannot be generalized. I conclude that during so these patients who had low self-efficacy can be monitored, and they can be given interventions like group therapy, motivational interviewing, etc., to prevent further relapse. So this self-efficacy tool can be used as a follow-up measure in future, sir. So these are my references. Thank you.
Thank you, ma'am. Sanna, sir, can we start with the questionnaire?
Yes, ma'am.
Arvind, sir? Prasanna, sir?
Good afternoon.
Good afternoon, sir.
Very effort to find out how pandemic has actively helped the people to abstain from alcohol. That's what I would take as positive. What is your opinion? Has pandemic played a positive role or negative?
Yeah, it has created an impact by increasing the severity of dependence and presence of withdrawal symptoms, sir. So they face a lot of interpersonal conflicts, and thereby they get relapses more often, sir.
Okay, according to you, the self-efficacy was high among?
So this self-efficacy was high among those with mild dependence, sir. Whereas those with moderate to severe dependence, their self-efficacy was low.
Okay, so going by this, how can
Yes,
this
sir.
impact of pandemic taken forward? Positive impact of this pandemic, how can this be taken forward is my question.
Not audible.
Sir,
Did
sir,
you hear my
because of this
question?
pandemic, yes, sir, I'm able to hear, sir. Sir,
So go
because
ahead.
of this pandemic, there is a forced abstinence, sir. Most of the men were not able to get the substance because of this lockdown. So this can help in maintaining the abstinence in the future, sir.
Okay, thank you.
Thank you, sir. I would like to thank the organizers for giving me this opportunity, and my guide, Professor and HOD, Dr. Kannan, Department of Psychiatry, Chengalpattu. Thank you, sir.
Thank you, ma'am.
We would like to thank all the contestants and judges for taking out their precious time. Judges, we request you to give the concluding remarks.
Hello.
Yes, sir, we can hear you.
Yeah, we thank MSR Medical College for giving this opportunity All the presentations are very good. It are unique presentations because of this COVID-19. So all the topics were very nice. Okay, thank you. Hello.
Thank you.
Good afternoon.
Yes, sir.
A very nice effort on the part of those postgraduates from the various colleges to have selected those topics of real interest. And some of them can be really taken forward for the benefit of the community. And I would like to thank Dr. Lalita ma'am for having given me this opportunity to judge the young scientists or young researchers of our country. Thank you.
Now I request all the presenters and judges to switch on their cameras, please.
It's not audible.
Can you switch on your camera?
Dr. Arvind, you can also switch on your camera.
ವೆಬಿನಾರ್ ಮಾಡಿದಾಗ ಈ ತರ ಫೋಟೋ ತಗೋಬೇಕು.
Insight. Thank you, everyone. And we just want to remind you all about the catch talk after this that starts at 12:30. Thank you, sir.
Thank you.
Thank you.
Oh, organizers? May I have the organizers, please?
Yeah. Yes, sir.
So, to whom should I post this scoring?
Sir, you can.
Send it by email.
Yeah, there's an email ID which I've attached to the mail for judging invite. catchcon2020@msrmc.com.
So, whatever material I've got. Hello, whatever email I've got regarding the judging criteria and other things, for the same email, shall I respond? Thank you very much. I will do it. Thank you.